Hi there everybody, let's talk quickly about the basics of narcolepsy. So when I'm talking about narcolepsy, we'll get to the signs and symptoms here in just a second. I just want to talk about what causes narcolepsy in the first place. Right now it's thought that there's a complex genetic contribution. So there is a predisposition based on your genes. Now the thought is that there's abnormal neurotransmitter functioning. So there is going to be the immune system, which is there in your body, and normally it works there to fight off bacteria and viruses and whatever else invades into the bloodstream. However, here, those immune system cells are going to attack hypocretin producing neurons. Now, this would be a good time to kind of step back and talk about hypocretin. I'm also going to write another term, orexin, O-R-E-X-I-N. Now, there's two different names for the same molecule. And kind of on a side tangent, there are two names for the same molecule because two groups discovered this molecule in the body at the same time. Orexin came from one lab, and that kind of goes off of the naming convention of appetite. And then you also have the hypocretin, which is named based off of the hypothalamus, where these neurons are found. So hypocretin, like I said, it's produced in the hypothalamus. And what you'll see in narcolepsy is you'll see decreased levels of hypocretin or orexin, depending on how you like to call it. So the thought is that your immune system kills off these hypocretin producing neurons. Also, narcolepsy, it's going to be associated with the pons, the mesocortical limbic system, because remember the limbic system deals with your emotions, and as we'll learn here in just a second, narcolepsy is based partly on your emotions. So, let's talk quickly about the signs and symptoms of narcolepsy. One of the common triggers is it'll be triggered by emotions, whether it's stress or surprise. If somebody startles you, that could generate a strong emotion, laughing, crying, etc. So there are going to be four main symptoms or important points about narcolepsy that I want you to know. The first one is going to be excessive daytime sleepiness. Excessive daytime sleepiness. I'm just going to shorten everything here. Maybe I'll change color. What I mean by excessive daytime sleepiness isn't just, oh, you wake up in the morning, you're tired, you didn't get a good night's sleep. I'm talking about periodic sleep attacks. So, for example, you're driving down the street, all of a sudden there's just this overwhelming urge of sleep, of fatigue, of tiredness. You need to go to bed right now. So that's what I mean by excessive daytime sleepiness. I'm not talking about you didn't get a good night's sleep before, you're just tired throughout the day. These are periodic sleep attacks. The second main sign or symptom of narcolepsy is going to be cataplexy. Cataplexy. And what cataplexy is it's going to be a sudden, brief loss of muscle tone. So, for example, your body normally loses muscle tone during REM sleep. So at night, when you're dreaming, you're going to lose all the muscle tone in your body except for your eye muscles, of course, and your breathing muscles and the essentials, but your arm muscles, your leg muscles, you're going to lose function of them. In narcolepsy, you're going to have the same thing. And that's because, as we'll see in just a minute, the REM sleep cycle and narcolepsy are going to be interrelated. So one example would be you're walking in the grocery store, all of a sudden you lose muscle tone, you fall down, hit your head. And this can be associated with that strong emotional trigger, for example. I think there is a video on the fainting goats. I would really recommend you to YouTube fainting goats. And if you watch one of those videos, it will show somebody startling this pack of goats and they fall down. That would be an example of cataplexy, where your body just suddenly loses muscle tone. Third component of narcolepsy is going to be hypnagogic hallucinations. That should be a U. Hypnagogic hallucinations. And what that is going to be is it's going to be hallucinations right in that stage as you're falling asleep. Normally when you're going to bed, you will not have hallucinations. However, this is one of the characteristic features of narcolepsy. That's about all there is to say about that. And then lastly, we'll talk about sleep paralysis. So sleep paralysis is going to be unable to move as you wake up. So normally, like I said, during REM sleep, your body's going to be paralyzed, you lose muscular tone. However, when you wake up, you should have muscular tone. You should be able to move. And this is one of the more frightening features of narcolepsy is as that patient is waking up in the morning, or from a nap, let's say, they're going to be unable to move. It's kind of like they're trapped. Yes, they're still breathing. They can move their eyes, they're thinking, their brain's working, just they're not able to control their muscles. And usually this resolves in a few seconds and goes away on its own. So these are the 4 main points of narcolepsy that I do want you to take away. So let's move on to the diagnosis of narcolepsy. Usually you're going to involve a sleep study. And what a sleep study is it's going to be fancy word for it is going to be polysomnography. That's where they hook up all these monitors to your brain, to your eyes, to your chin, around the chest and abdomen, to your legs. They monitor anything from your respiratory rate to your brain activity to your muscle activity. So they're going to be monitoring multiple different points. Also, there is a multiple sleep latency test. So a multiple sleep latency test. And what it is it's going to provide 5 opportunities to nap at 2-hour intervals throughout the day. And what you'll see is 2 or more onset of rapid eye movement periods and 8-minute REM latency initiation. And that's going to be indicative of narcolepsy. So sleep latency, or how fast it takes to go to bed, is going to be 8 minutes or less. Let's see. This will be the best way to do it. So we have sleep latency and 2 or more sleep onset REM episodes. What does this mean? So going to bed in 8 minutes or less, or sleep initiation in 8 minutes or less, and 2 or more sleep onset REM episodes, which means that the REM episode occurs quickly right after you go to bed. Normally in our sleep stage, we go from being conscious and awake, stage 1, then transverse through stage 2, transverse through stage 3. Finally, we hit our REM, or the rapid eye movement phase of sleep. Then we'll go to stage 3, to stage 2, to stage 3, to REM, and you go through these different stages. In narcolepsy, what you do is you tend to transverse all those stage 1 through 3 really quickly, and you just jump straight into REM sleep. And it's this abnormal REM sleep that is the futuristic characteristic of narcolepsy. So for diagnosis, really it's going to involve a sleep study to diagnose it. You can also use hypocretin levels, because remember when we were talking about the basics or the pathophysiology of narcolepsy, I was talking about hypocretin or orexin. You can measure the level in the cerebral spinal fluid. Let me spell that correctly. Cerebrospinal fluid. You can look at the hypocretin levels, and usually it's 110 picograms. I can't write this. Less than 110 picograms per milliliter, or less. Let's try and clear this up a little. And that's also going to be pretty indicative of narcolepsy. You need to have these symptoms, or those 4 main symptoms of narcolepsy, present for at least 3 months. And usually, then to throw a wrench in everything, this is really going to be present in adults. Children are going to present a little differently. You're going to have a different cue to diagnose it. That's a little bit out of the realm of this video though. So what are some of the diseases on our differential? What are some things that kind of present similar to narcolepsy but are not? So you need to be thinking about idiopathic hypersomnia. Idiopathic meaning there's no clear reason, and hypersomnia meaning excessively tired. So that would be an unexplained version that is not narcolepsy of this excessive tiredness. But however, it kind of separates from narcolepsy because there's no early REM sleep, the no rapid eye movement sleep in this idiopathic hypersomnia. You normally go from stage 1 to 2 to 3 to REM. Also, naps tend to be unrefreshing in idiopathic hypersomnia, and there's no cataplexy or the loss of muscle tone. Also need to consider depression because you have altered sleep status during depression, usually harder to sleep, delayed sleep phase syndrome, poor sleep hygiene, a whole number of things. So we do a sleep study, we're able to diagnose narcolepsy. Now how are we going to treat it? We have a couple different options. We have the non-pharmacologic and we have the pharmacologic. Alright, so in our non-pharmacologic treatment of narcolepsy, what you can do is you can schedule regular sleep hours. So always schedule that at 9 o'clock at night you're going to be going to bed. You'll get 7.5, let's say 8 hours of sleep per night and wake up at a predetermined time. You do that every night, weekdays, weekends, and learn a sleep cycle. Also, you can schedule regular naps. So regular bedtime and regular naps throughout the day. The thought of that is to hopefully combat some of that excessive sleepiness by trying to take timed naps. Now, more of the mainstay of treatment is going to be our pharmacologic treatment. What drugs are we going to give for narcolepsy? What you'll see is you'll see methylphenidate. Is going to be a good one to try and treat the excessive sleepiness. So methylphenidate is going to be a stimulant, and it makes sense that if you have excessive sleepiness throughout the day, you'll need a stimulant to try and keep you active or mentally alert. Some of the side effects of the methylphenidate are going to include headache, irritability, GI complaints, etc. You also have modafinil. And usually you'll see headache as a side effect of that. However, these drugs are going to be used to try and keep the person awake and ward off the excessive daytime sleepiness. Like I said, methylphenidate is going to be a stimulant, so really any of the amphetamines can also kind of work. And then also we need to treat the cataplexy, the loss of muscular tone. So what we're going to use, or what's used commonly as a first-line agent, is going to be sodium oxybate. So sodium oxybate, it really also helps with the excessive daytime sleepiness, but it may have some crossover into treating the cataplexy. Also, if these don't work, there's some off-label use, such as antidepressants like fluoxetine, clomipramine, etc. And then children, if you're diagnosed with cataplexy as a child, or narcolepsy as a child, then really there's no good proven drug to use. You may try the modafinil, you may try the sodium oxybate. The FDA at this point in time, to my knowledge, has not approved a drug yet for narcolepsy in a child or a pediatric patient. I do have my references. I believe it's just through Wikipedia, and then also the one listed here, and also the knowledge that I gleaned on my clinical rotation. If you have any questions, be sure to ask. Otherwise, thanks for watching.